Thanks very much, Vera, and I'm Ros, and if you can't hear at the back, if my voice starts to fade away, just put up your hand because I can pitch it quite a bit louder. Can you hear me at the back at the moment, all right? Is that yes or no? Hands up if you can't hear. One or two can't. Right. Well, I will talk as loudly as I can. Linda's got a microphone of sorts we might be able to get going, but what I'm going to be talking about today, before Linda talks, is about the diagnosis and management of this condition. There are a few seats up the front, by the way. Oh, thank you. That better? Yeah. I'll do my best. I'll get a bit cack-handed because I've got to work this as well, but we'll see how we go. Thanks, Linda. Maybe if I plug it in.
Yes.
That's still working? Yes. Yep, good. Okay, well if it fades, put your hands up. So I'm going to talk about how we diagnose and manage the illness, and I'll touch a little bit on some of the up-to-date research, but that's her main topic. She's going to bring you up to date with the research going on at the Open Medicine Foundation. So just to start off, I'm sure this is probably how many of you feel, and hopefully will not feel too much like that by the end. And these are some of the topics we will cover today, just to bring you up to date with how, as doctors, we cope with this very nasty, devastating illness. Just a little look at some of the underlying pathology, which will be enlarged a little bit when we talk more about the research, but we now know there are lots of abnormalities going on within your body if you've got this illness, and there are abnormalities in the immune system, in the brain, which we talk about as neuroinflammation. It may well turn out to be an autoimmune condition like lupus or some of the thyroid disorders. There are certainly abnormalities in the microbiome, and that may be a new term to you, but the microbiome is the contents of your gastrointestinal tract. About 1 trillion or more bacteria roaming around in your intestines and possibly out of balance or abnormal in this illness. Linda will enlarge a lot more on what we call metabolomics. And there's also a lot of talk about whether there are abnormalities in the mitochondria, which are the little powerhouses that produce energy in every cell in your body. This is rather like a prolonged post-viral syndrome. We often hear people having, that label put on them, suffering from post-viral syndrome. And as I talk, you'll realise that this is a lot of common ground and much the same sort of thing. There's a large range of severity of people with ME, and I'll call it ME, CFS intermittently because different countries call it different names, but we are talking the same thing. But there are people who are really severely ill. They won't be here today. They will be the people who are bedbound, possibly in a darkened room, unable to do anything, through to those who are probably at about 90% of health, able maybe to work and attend school and live a reasonably normal life, but the side you don't see is the fact that they probably have to rest up far more than the average individual would. Number of factors we know that seem to predispose or lead you into the possibility of this illness. There may well be genetic predisposition. In other words, you are born with a vulnerability to many, many diseases. Fortunately, we don't get them all, but we probably all carry that vulnerability to all sorts of things. Women more than men tend to get this illness in about a 60-40 split. There will often have been either mental or physical distress in the lead up to the illness, which perhaps makes you a little bit more vulnerable. Your system is a bit run down. Most people will say that there has often been a period of sleep deficit in the lead up, and there may well have almost always been some sort of viral illness. So those are some of the things that can lead into the final illness, the trigger. Almost always a viral illness. illness, but not every time. And there could be things involved like over-exercise. So a lot of athletes often get this illness. I've seen a lot of quite well-known athletes in New Zealand. We're very much a rugby playing nation, as you are here in Ireland, and I've seen a few of our top rugby players who ended up with this. In fact, the person who fronts our organisation in New Zealand is an ex-rugby captain, New Zealand rugby captain. Some people will say their illness started after exposures to toxins or an accident, surgery, sometimes having a baby, immunisations, lots and lots of possible onset triggers. And certainly those kind of people get it. It occurs in about 4 per 1,000, and that equates to somewhere around 20,000 in Ireland. And obviously it affects all age groups, all ethnicities. It's no particular type of person that will get this. That just gives you a little bit of a background picture of what may happen after glandular fever. Now, we all probably have known of someone with glandular fever who ends up very, very tired after they've had their phase of acute illness. And just to try and explain, on the far left there is an acute event, such as when you get the infection, your immune system fires into action as it should, and that's working away at helping to flatten the bugs and get you over the infection. And when the immune system is activated, you feel very unwell, often feverish, sore throat in this illness, glandular enlargement. All the symptoms are very typical of a nasty flu-like illness, and those symptoms are due to the activation in the immune system rather than the actual bug. And then, so you get that immune activation, feeling ill, and about 90% of people will kind of come back down to normal over about a month. About another 9% are going to take about 6 months to recover from glandular fever in a bit of a wave-like fashion, and we call that at that stage post-viral illness or post-viral syndrome. And then about another 1% are going to take much, much longer, anything from 6 months to years. And again, the wave-like pattern of remissions and relapses. And although I put stress there as possibly being aggravating factors, I don't just mean mental stress, though that is a factor, but sometimes pushing the body hard and putting the body under stress can be an aggravation. The symptoms I won't enlarge on, we haven't got time to go through them in detail, but the top 3 symptoms would be the main ones that people will have prominently in this illness, again at all levels, from the very severe through to quite mild symptoms. So fatigue is almost always the cardinal factor, and it's fatigue that's very different from the fatigue that you might get after a game of tennis or a day at work, whereby you have a meal, you sit back, you have a night's sleep, and you feel fine the next day. You're refreshed. In this illness, people will often say, well, I try and go to sleep or I try and rest, but I don't actually feel any better. Recovery is always prolonged. We have a condition associated with what we call post-exertional malaise, whereby if you exert yourself, you don't feel a lot better, which is what a person who would be suffering from depression would notice. A depressed person who perhaps is encouraged to go out for a walk or a run will often feel really good afterwards. They get a vibe of a really sense of feeling well-being. Whereas the person with ME might go and try and have a vigorous walk, and they come home and they feel really stuffed, really unwell. That may be delayed for a little while because they often get a bit of endorphin release with the exercise and feel quite good for an hour or two, but then it hits them and they can feel very, very debilitated and very tired, and that will often take several days to be overcome. And then we have what we call cognitive problems, whereby you get this brain fatigue, or what most of my patients describe as brain fog, and they really can't concentrate for very long. Their memory is shattered sometimes, and certainly for students and people trying to study or work in a very kind of intense mental job, it becomes very, very hard. So I think those three top symptoms would be the ones most important. We can certainly allude to some of the others as we go. Just to mention fibromyalgia, because a lot of people have been told they're suffering from fibromyalgia, and I even wonder what it is, or think it's a separate disease. Fibromyalgia is not really a disease in its own right. It's a condition, and it relates to musculoskeletal pain, the pain that occurs in muscles and joints and ligaments and so on, usually. But it can also mean, and has become to mean, chronic pain in other areas of the body. And the issue is that there often is no real explanation for the pain, or the pain is far more severe than it really ought to be. And Michael Butler, who actually is in Auckland, where I come from, has been very involved in researching what is going on in the brain in fibromyalgia, and they have found some very real chemical abnormalities there, and they're now calling it central sensitization syndrome. I'm not going to go through everything on these slides. This is a kind of short issue today of trying to bring in as many factors as I can. But between us, Linda and I will cover some of the gaps when we have a question time at the end. There are lots of different criteria for making a diagnosis, and you might wonder what that means altogether. As doctors, we're trained to make a diagnosis according to a kind of checklist, and this sort of is so for most illnesses. A lot of people imagine there's always a magic test that you can have done that proves you've got something, but in fact if you looked at the many, many hundreds and hundreds of diseases that there are, the majority we don't actually have a set blood test. So this illness is not that different in many ways, though I think we're getting closer and closer to the possibility of a blood test, which is very, very exciting. But we have these different criteria, and I don't think you yourselves need worry about all the changes and upgrading of criteria and even changes of name of this illness. When I first learned about this illness, it was called royal free disease, and we've been through many, many name changes since then and criteria changes. But each set of criteria that are produced are kind of bringing it a little bit more accurately towards making a diagnosis, rather than maybe saying, oh yeah, well that group of people all seem to have chronic fatigue syndrome, and then we find out as time goes by that perhaps 20% of them don't. We're getting more and more accurate in our little checklists. So none of the criteria yet is absolutely perfect, and it needs for the doctor to have something very, very simple. And most doctors that I know, and it may vary from country to country and place to place, but most are using the set of criteria known as the Canadian criteria because they're quite simple for the doctor to use. And the Institute of Medicine in America have come up with a simpler form of criteria, but we're again not quite sure if it's the best option. I'm not going to go into that. So what happens when you go to the doctor? You get, first of all, not much time to see the doctor, and I think that's a big, big problem. Every new patient I see, I spend an hour, and I think the average GP here and in New Zealand has about a 15-minute slot for you. So it is quite difficult for the doctor to make the diagnosis of a condition which is very, very complicated. And believe me, this is one of the most complicated illnesses that I've come up against in my whole medical career, and it's getting more complicated by the day actually, rather than simpler. So it's not an easy diagnosis for the GP, and it's really a detective trail with a process of elimination of other conditions. So you may well, as a doctor, be looking at a list of, let's say, about 500 illnesses that have fatigue and some of these other symptoms associated with the fatigue, and you've got to gradually narrow the field until you come down to thinking, well, this is most likely to be ME. And the patient, of course, feels very relieved to get a name for their condition, and many people have said to me, well, I felt so much better once I knew what was wrong with me. Well, it doesn't exactly cure your illness to be told what's wrong with you, but it helps you, at least you've got a track that you can now follow with a management plan, something you can tell other people, and it sort of helps, I think, to have a diagnosis. And the doctor will do many blood tests and other tests if you've got specific symptoms. For example, you've got chest pain, you might have an ECG done. If you've got a cough, you might get a chest x-ray and so on. So you get lots and lots of tests done. And it's pretty upsetting for the patient to be told at the end of it all, well, there's nothing really wrong with you, all your tests are normal. It could be ME. Well, that picture actually goes back about 40 years. So, we have come a long way since then, but I think what was being said now is often still said to patients, but at least the illness is getting better and better recognition worldwide. I think really we are finding, certainly in New Zealand and Australia, that doctors are becoming much more educated about the illness and acknowledging it much more readily. And I think it's fair to say that even though many of the symptoms seem to suggest to you as an individual that you've actually got an infection, a recurrent up and down type of thing, in fact, when you have blood tests done, even at the time of your most severe illness, there's nothing in the blood that would suggest necessarily active ongoing infection. There are a percentage of people who do have some sort of underlying background of infection, like a persistent herpes infection or cold sores breaking out on the lips, that kind of thing, that keeps recurring. But the majority of patients, when they're going through their acute phases, there's nothing in the blood picture that would make one think they have an infection, which again is frustrating. We as doctors have what we call a list of differential diagnoses. These are things which many diseases that have mimicking similar sets of symptoms, similar picture, and we have to go through. This is just a small list of the big total of the things that we're trying to really make sure that person doesn't have. It's also important to realise that when the doctor says to you, oh, you need to have a psychological review, or maybe you need to see a psychiatrist, the doctor is not necessarily saying, oh, I think you're a nutcase. The doctor is actually saying we need to really be sure that you haven't got a psychiatric condition. And I think a lot of people get very worried when their doctor's beginning to talk a little bit about the psychiatric aspects, which they may have or may not have, because most patients are very aware of the fact they've got a very physical illness, and they don't like the thought that other people might think they have a psychiatric illness. But my feeling is the main reason to have a psychiatric review is to make absolutely sure that those sorts of things are put aside, and the doctor can then say, well, no, you don't seem to have a psychiatric illness. We can really now focus on it being a much more physical condition. I think the other thing to say is too that if a person is depressed or very anxious, then we have to treat those things, because really, officially, we can't make a diagnosis of ME in the presence of quite marked depression or anxiety. We need to get those things out of the way. So sometimes suggesting treatment is a very good thing from your point of view. So we have a diagnosis of exclusion. We try and categorize it into the type of ME you might have, which may be all to do with throat and soreness and fever, or it might be more of a neurological illness for some people, and for some people it could be very much more of a rheumatological set of symptoms, and often the management plan is a little bit different depending on what sort of category of illness you're in. We need to also make sure our patients have ongoing surveillance, because just because you've got a diagnosis, it doesn't mean it's absolute. It may not be accurate. And I've found that of the probably 7,000 or 8,000 patients I've seen in the last few years, 30% of them we've ended up with a different diagnosis. So however knowledgeable the doctor is, they may still not get it right, because this is a very difficult illness to diagnose. So people do need ongoing surveillance, and it's really important to report new symptoms or change of symptoms, because that may be giving the doctor clues to what really might be going on. I don't want to scare you, but that's the way it is. Management plan is very important. Once we have a diagnosis, we need to be able to offer our patients something. It's no good saying, oh, you've got ME, just go home and get on with it. You need a plan. And that's something, again, which I think is beginning to be taught, certainly much more in medical school in the country I come from. And there are a lot of other people in the person's network who are going to get involved in the management plan. It may be their family, maybe other friends and colleagues, it may be the doctor's nurse, the practice nurse, physiotherapists, and so on. But the more you can get involved with these people, the better the chances are you're going to do well. And so we need a correct diagnosis, and then we acknowledge and support the person and try and educate all those around them, because the more those around you understand, the better you'll get treated. And then we have a sort of lifestyle plan, which we'll go through very briefly. We know for sure stress aggravates every illness in the book. It doesn't matter what's wrong with you. If you're stressed, you won't get over a cold very quickly. So stress needs to be addressed, but we're not saying, oh, this illness is all due to stress. What we're saying is that stress could aggravate, and if you can keep your stress under wraps or deal with it, you're going to do better. And so you need to acknowledge that and deal with it as best you can. Walk away from things if necessary, but learn some really, really good relaxation strategies, which could be anything from deep breathing to listening to music, which is very powerful, to self-hypnosis, meditation, and so on. And some people will definitely need counselling, and sometimes people will benefit from what we call cognitive behavioural therapy, which is really understanding their illness better. And learning how to handle it better. Then we look at exercise, and everybody begins to groan and look a bit scared when I start talking exercise, understandably, because we know for sure that with this illness, too much exercise can lead to serious relapse, and also there's not really now so much ongoing evidence that exercise is helpful in this condition unless it's managed very, very carefully. However, if you lay on the bed all the time and never move a muscle, inevitably that's not very good for you either mentally or physically. So even for people who are very severely ill, I would encourage, just doing things like that, making facial movement, sometimes having a physio help with just moving muscles and things, because you do need to use your body to keep your circulation mobilized. But if you push hard and try and do too much, such as the so-called graded exercise, which has been mentioned a lot in the past, that can certainly lead to relapse. Ideally, too, people should, if they're able to exercise, keep it at a very, very low level. Nothing, I say to my patients, nothing that makes you sweat, pant or heart race. You're not training for a marathon. Going to the gym can be a big mistake. Later on, if you're getting better, then a very careful paced approach can be helpful. And, little and often, rather than one big thrust and then crashing down and having to spend 3 days in bed. Real caution with exercise, and it often helps in the early stages to do your exercise, if you're going to do any, laying flat, because you get better oxygen and circulation to your brain that way. Whereas if you do your exercise upright, often the circulation falls into the feet a bit and you feel mentally quite empty-headed. So, preparation, building up slowly, and not listening to other people who tell you must pull your socks up and go to the gym, because that really doesn't work. Nutrition, it's very important to have good nutrition, but again, there's no magic diet out there. People will have tried anything and everything. There's so many books out there, and at the end of the day, you've just got to eat sensibly and well, little and often, because if you overload your stomach, everything's on go slow and the food seems to sit there and you can feel bloated and uncomfortable. And also a lot of energy goes from up here in the brain, has to go down there to then work away at that great big heavy meal, and again you can feel quite ill afterwards. Most people will benefit from a little bit of extra salt, and we're not talking people who've already got high blood pressure or heart disease, but the average person with this illness, ME, who doesn't have any cardiovascular issues, probably will benefit from having extra salt through the day, because what extra salt does, it improves your circulation, it improves your blood volume, which might be a little bit depleted, and some of those symptoms of woozy lightheadedness are all due to the fact that you may well have a very low blood pressure and possibly low blood volume, and you're not getting enough circulation to your brain. So a little bit of extra salt can be quite important and helpful. I won't go on and on about supplements. Many people will spend their life savings on the latest thing that's out there that's said to cure everything. And if we had a cure-all for this condition, we'd all know about it and we wouldn't be sitting here today. We use supplements if you've got a deficiency in your blood. A woman who has heavy periods may be low in iron. Maybe deficiency in the diet, so if you're unable to eat dairy products, for example, you might get quite low in calcium. And sometimes there are supplements which help a particular condition. And I'll put a little list up of some of the things I've found to be helpful in this illness, and there has been some supportive research. I won't spend a lot of time on it because we can perhaps spend a bit of time with the questions, but those are some of the things that would have been shown to be helpful in this condition. I would particularly put a finger on magnesium, because magnesium does seem to help some people with sleep, which is a major problem in this illness. It also helps a little bit with muscle cramp and muscle pain, the so-called myalgia. And I would also mention vitamin D, because if you are ill, you don't get outside very much often, and to metabolize vitamin D properly, we need sunlight on the skin. And even in New Zealand, which tends to be a very sunny country without too much pollution cutting out the sun, we find people with this illness are often very, very low in their vitamin D. And if you're low in vitamin D, you will be more tired. So you want to try and get out there for 20 minutes every day with the arms and the face exposed. You don't have to be in bright sun, but sitting in the shade but in the daylight, unfiltered daylight, that will help your metabolism of vitamin D. You can obviously take vitamin D as well. We have a lot of people in New Zealand who have B12 injections, and there is some good research to back up this possibility of it being helpful, and I've had a number of patients who've done very, very well on B12. It seems to improve the mental state. And then we have, as doctors, a huge range of potential medications, and again, we would need to be here for about 2 days to go through all this in detail, so we obviously won't be doing that. You'll all be suffering from post-exertional malaise probably nearly already, but just to show you, there's a range of medications we can use, and this all does depend a little bit on the individual symptoms. because I think with any illness, if you can relieve even just one set of symptoms, that person's quality of life will improve a lot. So we'll often be focusing on perhaps what that patient is suffering from particularly, most severely, and that might be pain, it might well be depression. With females, certainly hormone replacement is sometimes useful and helpful. And, I will go through one or two of these things. Just a picture of a sleep cycle, just going off track a moment. That is a fairly normal sleep cycle, and you will see there are two phases there of what we call deep level 4 sleep, the low phases, and then at the end of about 8 hours, the average person will wake up and should feel fully refreshed and sparky and ready to face the day. A person with ME will very rarely feel refreshed. And there's probably a lack of that deep level 4 sleep, which is the time when you normally will produce all the hormones and chemicals that have a healing effect on your body. And if you're missing out on that part of sleep, sometimes your brain will go on and on sleeping for hours. And people will often say to me, I've slept for 14 hours, I'm still not refreshed. And they're missing out on the swinging changes in the sleep cycle. So many of the researchers will say, until you get sleep right, nothing's going to come right, because that is the time when your body produces the hormones and chemicals that will have a healing effect. So we use lots of different things for sleep management, and again, I can't go into the detail now, but obviously good sleep routine is important, getting yourself prepared properly and relaxing in the lead up to bedtime and so on. I need to mention here, because it's really quite topical at the moment, that if you have tablets and screens and phones and all these things, you should turn them off for 1 hour before bedtime, because the so-called blue light affects your brain cells and you can't sleep as well as you ought to. So turn those things all off. Medication-wise, the one I would use most commonly would be the tricyclics, and they are things like nortriptyline and amitriptyline, doxepin. There's a whole family of them. They're very, very old-fashioned antidepressants, but we're not using them here to treat depression. The people in sleep clinics and pain clinics will use them in very, very tiny doses far too small to treat depression, but they have a very positive effect for most people on their sleep cycle. But there's several things to say with this illness. First of all, many people with ME cannot tolerate very big doses of medication. They have an extreme sensitivity to medication, and therefore we have to use whatever we're going to use very, very tiny doses. So if I was using nortriptyline, for example, I would use about 5 milligrams. And the other thing is, everything's on go slow in this illness, so you would start thinking about that too well ahead of bedtime. And if you're going to take nortriptyline, you might need to take it 5 hours before bedtime in order to get to sleep at, soon after you go to bed and put the light out. That way too, any hangover effect is usually over by the waking up time in the morning. So certainly the tricyclics are useful, but there will be some people they don't work. Some people need higher doses. Melatonin's a good additive or alternative for some people. And the one at the bottom is particularly useful for those that have what we call restless leg syndrome, RLS. That's a common symptom in ME. You can't get to sleep, keep moving your legs, not just legs, sometimes arms, twitching, and the Repenetrol is a very, very useful medication for that. Autonomic dysfunction is that woozy headedness when you stand up suddenly, and the drug we use is just above the bottom, the fludrocortisone. That can help your body retain the salt better, so that there may be some benefit there. Not necessarily for everybody, I might add, with all these medications. Everybody's so different, and I'm sure if we gave everyone in the room kind of going over, as it were. You all have an almost different illness with different sets of symptoms, different responses to medication and so on. Pain control is a huge area, and many people take all sorts of things and get very little relief. Even you coming down the list to opioids, which are things like morphine, often won't do much at all. And sometimes the simpler things like massage and warmth and acupuncture are more useful. But the ones that are interesting really are the two at the bottom, which are the anti-epileptics. That's gabapentin is the one that we use in New Zealand quite a bit. Its other name is Neurontin or Nupentin, and that has to be taken in a gradual build-up from a very tiny dose, and it may take anything up to 3 months to work. But for people with very severe chronic ongoing pain, it can be really excellent, but it's a question of gradually getting used to it. And then there's a lot of work going on now in various places with the drug called low-dose naltrexone. And naltrexone is a drug that is used to help people get off heroin and hard drugs. And if you kind of get ME, people thinking, well, that's certainly not me. We hope it's not you anyway. But the rheumatologists around different parts of the world have found that very tiny doses of naltrexone, and I'm talking a fractional dose, can be quite helpful for chronic pain in ME, and also help some people with a sleep disorder. May help because it relieves pain, and you obviously sleep better if you're not in pain. I won't talk about antidepressants except to say they do have a place in making sure that we've dealt with depression properly. And for some people, some of the modern antidepressants do have quite an energizing effect. I won't go there, but I will talk about estrogen, because estrogen is just the thing I like to mention, because so many women with this illness do have menstrual problems, and their menstrual problems are worsened, let's say. And if a younger woman goes on the pill, often it will alleviate quite a lot of her ups and downs with menstrual cycle and with her ME symptoms. And the older woman will often do very well on small doses of hormone replacement therapy, because estrogen does have an effect of improving brain blood flow. It also does help sometimes with muscle and joint discomfort. It organizes your brain function a little bit more efficiently. And also there is some evidence that it quietens down some of the changes that we see in the immune system in this condition. So hormone replacement has got a role, even though there are a few side effects and worries about it. Many women will say, I'm not going to worry about the side effects, I feel so much better on it. I'm talking the long-term side effects, the long-term risk. They say, I'm not worrying about the long-term risks. I'm more concerned with my day-to-day life, and I feel great when I'm on estrogen. So that's the answer I get from a lot of women. And I think also we know for sure that many women with ME do very well in pregnancy, and that's probably because, again, they have high estrogen levels in pregnancy. I'm not suggesting you'll run out and get pregnant, and the men won't be able to, but it does have some benefit for some people. We're nearly there. There are a group of drugs called immune modulators which help with the settling down some of the changes in the immune system, but they are, again, mainly still in the areas of research or very expensive. So it's not something that people can rush out and just get from the GP. I mentioned their immunizations too, because I've had quite a few people who've had flu injections when they've got ME, and it really stirs up their symptoms. So I think if you need an immunization of any sort, I would be a little bit wary. Choose a time when you're at your best. Don't have immunizations that you don't actually really need. And obviously obviously if you're going to Darkest Africa, you have to have the works, but if you're living happily in Dublin, you probably don't need to have a lot of the things that might be being recommended. If you do decide to have them, just choose a time when you are not at your worst, for sure. The research I'm not going to talk about really, because I'm going to leave Linda to mention that, except there are probably a couple of areas of research which she may not cover or may not be involved. She's going to talk about the research in her organisation. The Australian team in Queensland are working very, very hard looking at changes in the immune system, and they have found some very real changes that seem very specific to this illness, and that may well lead on towards getting what we call a biomarker, which is a blood test that can make a more accurate diagnosis. So that particular team are doing some very interesting work. And the people in Norway, of course, you probably heard them talking about the drug rituximab if you've been following the work on the internet. And rituximab is an autoimmune drug that quietens down changes in the immune system and corrects the abnormalities in some of the cells that we call B cells in the system. Their work is very, very valuable and very, very important, and they are doing trials with this drug which we hope are going to prove successful. But the frustration for people with this illness, of course, is that the trials seem to go on, and why can't we have the drug next week? And I think it's because all drugs, there's potential for dangers and risks, and often they're very expensive, and it's got to be proven properly with proper drug trials before they're considered safe to use and suitable to use for a particular illness. We often don't know how long the drug might be needed for, what the long-term risks might be, and so on and so on. So the things I will just mention as we finish off my part of this presentation is we need to make sure patients avoid getting relapses. That's really, really important. And one of the ways that we can help with that is things like stress management and caution with exercise, and giving people advice about when and if they should go back to work, giving them proper education about the illness so they manage their life day to day well, and people around them treat them properly, and so on. They do need to have a regular review by the doctor. I've seen so many people over the years who will say, oh, well, I was diagnosed with this 5 years ago and I decided I wouldn't bother with going to the doctor anymore because they couldn't do anything for me. Well, it's important to say, yes, things do change and improve in our knowledge and ability to treat the illness, but more importantly, we want to make sure you haven't got anything else going on wrong with you. We want to make sure we got the diagnosis right, and just because you've got one illness doesn't mean that you can't get another, unfortunately. So sometimes people will have 2 or 3 things wrong with them, some of which may be very, very readily treatable. So we need to watch out for development of other illnesses, particularly as you get older. Need to sometimes incorporate what we call a multidisciplinary team, which means that if you, for example, start getting a lot of eye symptoms, you do go and get your eyes checked. You don't just assume it's all ME again. You go off and get a proper check because your eyes are very precious and there may be something wrong there. So, you need the eye specialist, or you might need the heart specialist or the rheumatologist or whoever. Just a brief mention of recovery rates. People always ask about this, and it's a hard one. Catherine Rowe in Melbourne has some very, very positive, good results for her child study. She's got a very large paediatric clinic in Melbourne, which has been going for years and years and years, and she's followed up thousands of cases. And overall, about an 85% of these children and young people have recovered sufficiently to be either saying they're leading a normal life or that they're leading a normal life with some limitations. Maybe they are no longer a star rugby player, but they can still kick a ball around, you know. So there are good results for children and young people. The results for older people vary tremendously, and I think it's fair to say that the younger one is the better one's chances of recovery from any illness, this one being no exception. But at the end of the day, you know, different results are being quoted by different organisations who've done research, and I think it's fair to say there is a chance of recovery even in people who've been ill for a long time, but the earlier the diagnosis is made as accurately as possible, the better your chance of recovery. So I'm going to stop there because I know Linda's got lots of exciting stuff to tell you, and then when she's done her thing, we can have some questions, and you know, between us we can probably answer quite a few. Now I've got to do a little bit of electronic